I think it would be, you know, not sponsored travel from our standpoint here. So just so I can, so they can put it in the travel budget, see how it fits, and then get the process started for that. And usually a month or so for domestic travel is plenty of lead time for that.
Okay, great. Thank you.
Thank you. All right, I'm going to go back on mute.
Okay, thanks. Looks like the joins have stopped. Right when I say that, somebody else joins. But welcome everybody to the May call of the newborn screening pilots. Just a reminder, as Danielle said, everybody's muted, but she gave you the instructions for unmuting yourself, whether you're joining by computer or by phone. Just a note that as we go through the meeting notes, that the red text notes when we send out the slide deck after the call are from the last call, so we keep track of the report from the states month by month. We do have a standing agenda. So with that, I would love to see if there's anybody new on the call today that would like to introduce themselves or their team.
Hi, everyone. Again, the feature to unmute yourself if you're dialing in by phone is *6. And if you're joined by computer, you can either press the microphone or the telephone icon. And you can also use the chat box.
Thanks, Danielle. So lots of ways to interact today. So with that, we usually start out with the update from the pilot. And by the pilot states, we mean the states that were supported by NICHD to conduct pilots of conditions that were recently recommended to the RUSP. So last March, or just a few months ago, we heard from New York State. They reported on MPS1, Pompeii, and XALD. So is there anybody on the call today from New York that wants to give us an update on your efforts related to these conditions or any other conditions, including SMA?
Hi, Amy, it's Joe. Can you hear me?
Hey, Joe. Yep, I can hear you.
Okay, yeah, I have updates for a few of what the new disorders we're screening for now. Just for updates for Pompeii since the last call, we had the last call as being a couple months ago, March 7th, is that right?
Yeah.
Did we? Yeah, okay, yeah, so since then, we've had 3 Pompeii referrals. 2, one was a carrier, one was homozygous for a variant of unknown significance. And then we had one that had 2 pathogenic variants, both were late onset pathogenic variants. For MPS1, we just had 1 referral, which was a carrier, but through screening, we also detected 3 other positives that were all just pseudodeficiency variants only. So those wouldn't have been referred, they would have just been reported as pseudodeficiency variants. And then we have an update for SMA as well. One SMA that had 3 copies of SMN2. To our knowledge, no treatment has started yet, and we're waiting confirmation for the diagnostic lab on that child. For ALD, we had quite a lot of hits in the past couple of months. We are now, I have more of a complete information for that and we've had 1.3 or so million kids screened. Now we are up to 37 boys that have been detected with mutations and 39 girls that have been detected with mutations. Most of these are confirming by diagnostic lab testings. We don't have some of the latest ones yet, but that's the way they've been going. And that's the New York update.
Joe, can you remind us what you guys are doing for SMA? I think we heard a little bit about SMA and the analytical testing at the APHL Newborn Screening Symposium. Will you remind us how you guys are screening for SMA?
Well, we are screening with the TREC assay. So it's multiplexed real-time PCR, but maybe Michelle or Colleen to give more specifics if you need more of that, but that's what I've got.
When
we look for SMN copy number, 2 copy number.
Mm-hmm. So do you do the multiplex with TREC for the SMN1, and then how do you do the SMN2 copy number?
That I don't know.
Okay. Okay, I was just curious.
I should pay more attention.
That's okay. You've got a few things going on. Any questions for Joe or the rest of the team?
Yeah, this is Angela from Georgia. Can you hear me okay?
Yeah, hi, Angela.
Hey.
Hey, Angela.
Hey, Joe. Joe, I'm wondering, I know SMA isn't your project, but I'm wondering if you know if you guys are getting any false positives. And I'm probably going to ask everybody this just so y'all know, because that's what we're working on.
Not to my knowledge, because of the way the assay's set up. I don't think so.
Okay, great.
Yep.
Thanks, Joe.
If I hear differently, I'll let you know.
I appreciate it. Thank you.
Yep.
Any other questions for Joe? Okay, Angela, you're up.
Okay, good. I'm back. So yeah, I'll be honest, we are doing a brief 1-month pilot on NPS1 in Pompeii, and I don't have those numbers. I apologize. I didn't even think about that because it's just not big on my radar. But I don't think we've had too much come from that. Like I said, it's just a brief 1-month trial because we're implementing a different methodology. We're using digital microfluidics now, whereas our original pilot was completely mass spec. So, and I don't think in this short amount of time we've had any real cases of anything so far, and we're wrapping that up. But we are doing SMA. And just as a reminder, we are multiplexing that with our SCID assay. So looking just at SMN1 copy number, not SMN2. To date, so we started on February 6th. So to date, we have screened 32,544 specimens, which is approximately 28,608 children. We had 8 children screen positive, and out of those, 2 confirmed and 6 are false positive. So, and part of that is, the algorithm we have been using was to, we not just pick the ones with no count. We had stopped, our cutoff was anything above 37 cycles on the 37 on the CT count. I think I'm saying that right. And so what we're finding is really those 2 confirmed cases were the ones that had absolutely no count, and then everybody else is turning out to be a false positive. So that's part of the fun of doing a pilot. We're kind of figuring out how that's going to shake out for us going forward.
Angela, how do you guys confirm them?
We are getting SMN1 and SMN2 reflex via MLPA testing. Does that sound right?
Mm-hmm.
Good.
Okay.
You can tell I'm not the lab person, but yes, so we're sending those over to a confirmatory lab to do that.
Okay, gotcha. When you, maybe for next time, when you know the status of those 2 that were confirmed, I think there's been, I think at ACMG and at APHL, there was some discussion of the sort of results from newborn screening on SMN1 changes plus SMN2 copy number. And
Right. Well, and I can tell you actually our first kiddo, I don't know a lot about their results. Maybe I can find him, but he I know he had type 0, SMA type 0, so he was not doing great. The second kiddo, we literally just got those results yesterday, so they're fresh in my mind. On SMN2, he had 3 copies of SMN2. But it's still to be seen in clinic. So if I have any other exciting news, I will share that next time.
Okay, thank you. Let me make sure. So there's 2 people on the chat box. Okay, so this is Dr. Kajana. She couldn't just go back to New York since it's still SMA. Let's see. They have no false positives that they're aware of. They test for the SM1 deletion by qPCR. Or quantitative PCR, they only detect the presence of SMN1, so don't make carrier calls, and they're using a validated qPCR for SMN2, and also have another PCR that they use to validate and ready for approval. They only do SMN2 when there's a homozygous deletion of SMN1 detected. Okay. I think one thing, I don't know if any of you guys caught the, Dr. Kathy Swoboda's team had done a plenary session at ACMG on families who had multiple cases of SMA, and they were comparing the results of the SMN1 and SMN2 and then how that correlated with clinical features. And it wasn't always what we expected. So that's why I was asking some of those questions. It's just something in our work capturing that SMA data on the clinical side in the longitudinal pediatric data resource. So as we see some of the information come in, it's kind of interesting to see how that's playing out once things go to population basis. I always say, you guys in newborn screening sort of change a lot of what we're thinking about things as you find more and more things once you're screening so many newborns. So Cindy Wu has a question for you, Angela. She says, are you using the CDC qPCR V2 primers and probe for the SM1N1 deletion?
Cindy, that is a wonderful question, and I don't exactly know the answer to that. I do know that our lab is using materials from the CDC. I don't know if they have different types of primers, but I know Art Hager is our lab director, and he would be more than happy to answer that for you if you wanted to reach out to him or me, and I can pass that along. Or if you know Francis Lee over at CDC, hopefully he's feeling okay. And we've been working with Francis. I'm sure he would be happy to help also.
Great, thanks, Angela.
Sure.
So you guys, so with as a state, Georgia is going back to being live with NPS1 and Pompeii, and then you're doing your SMA pilot. Will you remind me how long your SMA pilot is going to run?
Yeah, it should be about 15 months. I think we have funding for 150,000 samples is what I recall. And our NPS1 in Pompeii is actually, that's just a very brief pilot. We aren't going live quite yet. We're hoping that we get funding here this coming fiscal year, and we're all crossing our fingers that maybe we'll start maybe towards the end of this calendar year. So everybody cross your fingers for that. And it would be NPS1, Pompeii, and ALD. And as part of that funding, we're hoping that we would also include SMA in that, so that when the pilot ends, it doesn't really end. We can just roll right into live screening.
Gotcha, thank you.
Yeah.
Any other questions for Angela? Thanks, Angela.
Sure.
In March, we heard from North Carolina, like Georgia, they're part of the task order for pilots and the pool of states that conduct those pilots. And so they were undertaking their screen of or pilot of SMA using their early check method. Is there anybody on the line from North Carolina that wants to give an update?
Yeah, hi, this is Jennifer. Can you guys hear me?
Yeah, hi Jennifer.
Hi, how are you guys doing?
Great.
So, so we are still currently screening for SMA under the Early Check program, which, just to remind everybody, is where we're asking for parents to consent for additional screening. We have screened a little under 2,700 specimens, and we have no screen positives yet.
So yes, I mean, you talked about using the PCR method, but not combining with SCID, right?
Yeah, since we are doing this under a consented protocol, not every, right now in North Carolina, every child is screened for SCID. So we decided to make this a separate assay. So only parents that consented are screened for SMA. So it is a separate assay than the SCID assay. I think future plans is to multiplex it once it's added to the North Carolina panel, but currently it is not multiplexed.
And then last time, Dr. Taylor, you talked about looking for exon 7 presence or absence. Will you remind us what your plan is for the SMN2 or for the confirmation once you find a case?
So if we find a case that's screened positive, then that child would be referred to follow-up, and the SMN2 copy number and confirming that there is no SMN1 would take place as a diagnostic test.
Okay.
We are looking at testing methods that we can do in the laboratory, such as digital PCR, but we don't have instrumentation for that currently. So right now it's just going to be, they'll get the SMN2 copy number upon confirmatory testing.
Did you say 27,000 or 2,700?
Yes, yes. Thanks, Joe. I see the comment.
Yeah.
That is correct. This
Everybody,
is 2,700, not 27,000.
who says people don't pay attention during these
I know, right?
numbers are important to laboratorians. That's awesome. Are you guys, and you guys at Early Check, you're building a laboratory, so you're doing the screening at your Early Check laboratory?
So we're currently actually screening at the North Carolina State of Public Health, where the newborn screening is done. However, we are currently building a laboratory, a screening laboratory on RTI's campus, and the plan is to transition in the fall from the North Carolina lab to RTI's campus.
Cool. I think we saw the plans for Dr. Bailey at the Newborn Screening Symposium. That looks cool.
Yeah. Mm-hmm.
Any questions for Dr. Taylor? Okay. And then in March, we heard from the Nebraska team, Julie and Crystal, about where they were at with several of these new conditions. So they talked a little bit about their advisory committee and their implementation rules and sort of some timing of the things that they were doing, as well as an update on some of their the new conditions and the totals. Is there anybody from Nebraska that wants to update any of those numbers from March, or talk about anything else that might be going on?
This is Karen from Nebraska. Can you hear me?
Yeah, hi Karen.
Hi. Crystal's not here, but on her way out the door, she told me that the numbers are not any different for MPS 1 or Pompeii. With the XALD, the numbers are increasing. We have not, well, let me see, I'm trying to pull them up because I wasn't expecting to do this, but so far we've only found one male XALD, and we have a predominance of female heterozygotes. And I think actually the any positive that we've had or any that needed further testing or referral in 2019, they've all been female, and I can't account for why that would be. It would seem to me, and looking at everybody else's numbers, that it should be half and half. But so far, we've only had the females. We have one that is pending the sequencing. The repeat was high, and one is pending sequencing. We have one that's still pending seeing the metabolic specialist. We had two that were confirmed positive female XALD heterozygotes, and we have one that is actually still going to have more testing. She had an elevated C26, and then the repeat was normal, but she is a cousin to one of the other babies who had a mutation. So we've asked the lab to go ahead and please check for that specific mutation, and we're waiting on the results on that. That's still pending as well.
Wow. That reminds me, Karen, thanks for that great update. You know, with XALD, it's sort of the, you know, one of the things that was talked about when it was nominated was sort of the testing of other family members. Do you guys have any policy related to that, or is it sort of case-by-case basis?
Yeah, I think it's sort of a case-by-case basis in the sense that, you know, it ends up being that the doctors who see the patients, you know, and when they're doing the family history or family tree, decide whether or not there are people who need testing and to try to approach the families about that, or not. And so that it kind of falls under that. I do know a few of the situations. The one situation where it's the cousin is somewhat difficult because the cousin who was had the mutation found is part of an adoption, and but the second cousin, the cousin that repeated normal that we're still testing, is with biological mom. We had one other that was seen and confirmed female. She does not have any siblings. However, parents are Cuban, and there's apparently quite a number of men in Cuba in the family who have some kind of neurological problem that they have not diagnosed, but they thought it was X-linked. So, you know, if they had been in the United States, that would have brought us another bunch of people, but since they're in Cuba, I'm sure they will transmit the information back to their relatives, but it isn't, you know, they aren't here in the United States to be followed up on. And otherwise, we haven't had siblings and things that people have been worried about. They usually do go after the parents to try to figure out who had the mutation or how that happened. The one in we had one female heterozygote in 2018, and she received that mutation from her dad, not the mom. But he is asymptomatic at this point.
Interesting. Do the other states that are testing for XALD have any policies or approaches to sort of testing, or?
No, I don't think that they have exactly a policy. I think that they just try to go with what the family's situation is and assess from there. I mean, we have two metabolic specialists. They talk to each other, and I think that they kind of try to come up with what they think is best to try to do with the families. But they, you know, in situations like the adoptive mom, you know, that she has no blood relationship apparently herself to the baby, and you know, I don't think that they were particularly interested. There was another family who the mom's mom, the grandmother, seems to be the matriarch of this very large family, and she really was completely resistant from my understanding. She at first was accusing the doctors of experimenting on her family, and once they, sat her down and talked to her and explained exactly what was going on, and how they did want to test further members of the family because mom has sibs, mom has other children, there's a bunch of people involved, and the matriarch, she calmed down and was no longer accusing them of doing some experimentation, but at the same time, nobody has come in to get any testing.
Oh, wow, interesting. Thanks, Karen, for that great report. Any questions for Karen in Nebraska? Are there any other states?
Hi, Amy. It's Joe. I have a question.
Sure.
I'm wondering if you said that when you do family testing that you actually, they're actually looking for the mutation in the family. Do you know if they actually do the genetic testing, or do they do very long chain fatty acids first and then go to genetic testing if indicated, from a elevated very long chain fatty acid result?
I think they're going with the very long chain fatty acids first. However, in the case of like the one child whose cousin had a known mutation, and the repeat C26 was within the normal range, they're just looking at that mutation at this point, but we haven't gotten the results back to see if she has it or not.
Yeah, it's interesting just because I wanted to point out, at least we had a meeting here about a month ago now, with people talking about ALD and harmonizing cutoffs and things. And one of the things that comes up is, if we're trying to look at a variant that's unknown and not well defined, the way of going about doing the genetic testing kind of dead ends things. If everybody has normal very long chain fatty acids, people assume then none of those family members have the point mutation, which may not be accurate, especially if it's sort of a borderline kind of a result on the child or the proband. So it could possibly settle a little bit more if more family members had point mutation and very long chain fatty acid testing done to get to a little bit better idea of what that variant might mean, whether it's pathogenic or not. And if somebody's healthy, and a grandfather, an uncle or something, and very healthy with that variant, then it might help out. But anyway, I don't know how we can get people to go to that mindset because it costs money.
Well, I know Dr. Rizzo is the one who was dealing with this family, although Dr. Lutz had the other family, so it's kind of interesting because the cousins are by different metabolic specialists. But, I know that he was interested in hearing, even though the repeat C26 was technically normal, he was interested in getting the follow-up to see whether or not there was the mutation. But I think too, he pointed out to me that you can miss female carriers, that they don't all have elevations. And so, and even I think he said that, some of the ones have low, very long chain fatty acids on their usual testing, and still might have an issue. So I think he does both with the hope that we're not missing anybody.
Yeah, I gotcha.
It looks
Thanks.
like, so Amy Gaviglio said, to echo what you two just said, that they found in Minnesota the molecular testing is especially important in females who may or may not have elevated very long chain fatty acids as carriers. In Minnesota, they started out not closing out females as confirmed or not, unless they have had both biochemical and molecular. One thing this points out, for all of you guys, and you know this better than I do, we started these calls to talk about the pilots that were ongoing, sort of under the IDIQ task order or under CDC funding or support and things like that. And we often talk about the conditions as more and more states add them. So in thinking about your harmonization approach and whether you guys can start capturing variants tied to, you know, the very long chain fatty acid results, or, you know, I think that's something that, you know, maybe the states along with CDC could kind of think through, and, you know, let us know at NBSTRN if there's anything we can do to help. I know we've been charged with sort of trying to capture the pilot data over time to be able to understand on the implementation pilot and research side what's happening in pilots. But I know there's so much information that comes along once all the states start screening. And you guys probably have approaches to capture all that data, but I think this is a great forum to talk about, you know, how to do that or how to organize it in case there's anything, you know, you guys want to use this time to sort of talk about.
Yeah, thanks, Amy. Can you still hear me?
Yeah.
Yeah, I think, you know, it's clear, or at least fairly obvious, that with the issue with females, and not all of them have elevated very long chain fatty acids even when they carry the variant. But where I'm being even more nuanced about and try to be more clear about is even when you have boys that have sort of borderline kind of laboratory screening results and where you get the very long chain fatty acid results, and there are cases where they're like, well, mildly elevated, what's it mean? There are even labs out there that don't have necessarily haven't established reference ranges for newborns yet. So you end up in this pickle, and I think, you know, especially in those cases where you have a variant that's really not that clear and there's no family history and things like that, but there's plenty of family members to check, that it might be you could clarify the significance of that variant, or at least get a better idea about it, and looking deeper into the family for both the very long chain fatty acids and the point mutation together. And I'm not suggesting you do it on every case, but just these ones where it's you're in that kind of like you really don't know, it was sort of a borderline result everywhere, and you're trying to decipher it. And that's what I guess I'm hope I'm being more clear with it in this case to explain the thinking. And that's some of the thinking that people had here when we got together and we're talking about this. Did you still hear me?
Yeah, that's great.
Yeah.
Thanks, Joe. One of the things I was gonna suggest maybe on an upcoming call, I know, you know, Mike Watson is one of the co-PIs of the ClinGen effort, where they're kind of curating newborn screen related genes and variants, you know, things like for Pompe, and maybe on an upcoming call, I could have him give an overview of that process. I know one of their visions is to sort of have the state laboratories, you know, feed into that pool of, you know, what are the variants we need to curate, what kind of data do we need to collect to be able to understand whether a variant's pathogenic or not. And, you know, you guys are the ones who are discovering all these new variants. So I think thinking through that sort of workflow might be helpful. And I could work on getting him on a call upcoming, and then also maybe talk to Dr. Cuthbert and the folks at New Steps to see if they want to sort of have a focused discussion on this effort. Sometimes I feel like we're wading into sort of the state practices area, but I love to hear you guys talk about these things, and we're interested in it, you know, from the genetic side, and, you know, trying to add to that body of knowledge of when you find a variant, whether it's pathogenic or benign, or, you know, if we don't know yet. So I think that's really helpful information. So I'll work offline with a few of those key people and see what we can plan going forward to have a discussion about this.
Sounds good. Thanks.
So Kate Tullis is saying, so she's wondering, is the thinking that the newborn screening programs would fund extended family sequencing, as we are bringing these on our, we're very concerned about who's going to be responsible, and the newborn screening fee payers are also concerned. So do you guys want to talk a little bit about that? Or I guess it's probably a mixed bag about funding.
It really is the issue at hand. Once the insurance companies, they only can get so much done. So figuring out how to get molecular testing on really the important cases of other family members that might be, you know, potentially having, you know, carrying that variant and perfectly healthy, that's just as good of information, I think, as the other way. So, but how to pay for it when people have normal, very long chain fatty acids. I think we're going to try to expand our thinking on it here anyway, but, you know, it means going back to our physicians and kind of making this announcement. We have to be a little careful about how we do that.
This is Karen again. In our state, we don't cover any of the costs for extended family members. But I remember at that XALD meeting that was in New York in January, that when Pennsylvania presented, they talked about having within their contract with PerkinElmer, who was doing their testing, and as they do our testing, that they had in their contract negotiated for, I believe it was 2 additional people to be tested once they find somebody who is has a positive screen. So I think it's an interesting thing. I mean, right away from the start, every time I talk to the doctors or genetic counselors, they always say that if more DNA testing is considered part of screening, it really helps get more of it done, and it also helps it to be more timely rather than trying to get prior authorization from insurance companies, which may or may not come through in the end. So like with the, you know, all of the new diseases we have, the SMA, or not the SMA, the NPS1, the Pompe, and the XALD, the sequencing is considered part of the newborn screen. And that has, they're very happy with that. But family members, I mean, I don't know how many family members you think you could cover already. Our metabolic specialists are talking about, well, they should have added a social worker and genetic counselor to try to track all these people down because they don't have the time to do it. You know, they're concerned about their patients and they're pretty busy as it is. And they're really wondering whose responsibility this is going to be in the long run.
One thing that your discussion points out, you guys, I wanted to look back to the advisory committee's recommendation to add XALD and whether they sort of thought through this, you know, approach or, you know, what you guys are experiencing with the extended family testing and if they had any guidance for that. So I've got a lot of sort of action items and notes that I'll follow up on with this XALD discussion for one of our upcoming calls. But is there anybody else that wants to add to the XALD conversation or give a report on where their state is at this month?
This is Jennifer in North Carolina, and I can just report on what we did for the pilot study. We didn't do the sequencing here in the lab, but we contracted out to the Duke molecular lab to do the sequencing on the dry blood spot. And then we received the report back so we could report it out with the newborn screening results, and it was included in the newborn screening. It was included when follow-up, with the follow-up information for the screen positive infant. So that's how we handled it there. And then also, as far as family members, since we did the whole gene sequencing on the family, we could do a more targeted sequence on the siblings and the parents that were identified, which brought down the cost of the genetic testing.
Do you, so using targeted sequencing, using the result on the newborn?
Exactly.
Jennifer, and then did you guys, have you guys thought about putting those variants in ClinVar, or do you keep them in a database, or, you know, where are you guys thinking?
So we are currently in the process of publishing a paper on this information.
Okay.
I think so the variants that we found, we found the variants that we found were, I guess, unique variants. So I guess they could potentially can be put into ClinVar. I can have more discussion with the Duke Lab on putting those in there. But the variants that we found, they were similar to, it was the same location, I guess, that were currently already categorized as pathogenic in ClinVar. They were just a different mutation. So I guess I would just probably need to have further discussions with the Duke folks just, about putting that information in there.
Okay. You know, ClinGen has a sort of community forum once a month or once every other month. And just last week, they had one of the community forum calls where they were teaching laboratories and clinicians, you know, who aren't part of like an overarching research project on how to submit to ClinVar and the importance of submitting from diagnostic laboratories. And, you know, I think like LabCorp and Quest and other people were on the call sort of. So I think they're trying to encourage that so that they can really, you know, utilize what you guys have done such hard work on, is figuring out what variants are important or clinically relevant. So yeah, I think that's really great. And when you guys publish your paper, you list those variants, right?
Mm-hmm.
Yeah. Gotcha. Okay. That's great. That's great. More paper writing. Awesome.
Yeah. But I'll see, because I don't know if that's something that the Duke folks have already done, or
yeah,
that's something that they're, you know, so
yeah.
I'll have further discussion.
Okay, thanks. I think they're really trying to encourage that and, you know, sort of get the word out, and then they're always there to help people know how to submit and things like that. Anybody else want to add to the XALD discussion or report on what's going on in your state?
It would just be interesting to know how the other states feel about the sequencing of, you know, ABCD1, because some states clearly don't have capabilities of including that in the newborn screen. However, it is important for the diagnosis, I guess, of the child. So it would just be interesting. I know Amy commented and said that's part of their clinical report information that they get. I know in North Carolina we have challenges as far as getting genetic testing done, especially for the, I don't know if Cindy Powell's on the phone, but I know she's mentioned to me that especially for the kids that are on Medicaid, genetic testing can be complicated. So I don't know how other states feel about that.
Amy, this is Karen again. When you talk about ClinVar, are you talking about, I mean, there's an XALD database of mutations that is, I think anybody can add to it. Is that the same as what you're talking? I haven't heard it referred to as ClinVar, but I don't know what its official name is. Maybe Dr. Orsini knows.
Yeah, it's not the same thing. What ClinVar is, it's actually a resource of the NIH, National Center for Biotechnology and Information, or NCBI. So NCBI has created ClinVar, which is designed to go gene by gene and capture all variants in a gene. And then also, so anybody can submit a variant to ClinVar, and they're trying to take databases like the XALD focus database. You know, there are SCID focus databases and XALD and a lot of other diseases. So they're trying to take the information from those databases and put it through a standard pipeline and into a standard way to display it. So one thing I can do, Karen, on an upcoming call is give a little overview of ClinVar. ClinVar is, like I said, where we keep track of. So you can see right now, I just did the search for the ABCD1 gene, and there's 462 variants that are reported, and then it tells you the rating, the clinical significance. At least that's the rating of who submitted it. It's not a curated rating. Another effort tied to ClinVar is called ClinGen, and ClinGen is where they have expert curation panels come in and they look gene by gene, condition by condition, and they validate those ratings for each of the variants. So if there was a way, you know, we could take from a newborn screening lab, say, variants, and they would put them in ClinVar, and then they would ultimately, you would add your clinical information, and then they would get validated, you know, through that effort. And so that's sort of what that was designed for. The involvement of newborn screening programs, I think, is a little bit new as you guys get more information on variants, and variants become more important to all of these results. So I think it makes sense to have a discussion on an upcoming call, and I can make sure that I highlight like the XALD specific database and how that's different or how it adds to this database.
Yeah, I think that's great. I think the problem with XALD is that it's a problematic disease in that the information is going to come down the line. It's probably going to have to come through the clinicians unless the newborn screening programs have good funding for long-term follow-up, which at this point, at least in Nebraska, we have none. But to decide, you know, what it's going to be, and then even knowing, let's say that it's pathogenic, it can be expressed in the same family in different ways. And then I think that that makes it even all the more confusing as to what the mutation at this point really, what they mean. And I know that it's got to be a very difficult thing for parents to hear, that, you know, we know this much, but we can't tell you, you know, what's in your future at all.
One thing too, you guys, this reminds me of a little bit too, is of Pompeii in the beginning, where there was a lot of sort of discussion from the newborn screening programs and bringing up clinicians. And we did have a few focused Pompeii calls with Pompeii clinicians on them who sort of talked through some of how they were experiencing the referrals and the results and things like that. So maybe that's something I can follow up on too, and see if we can begin some discussions with the clinicians who are receiving these referrals and sort of how that's working. I know for me, one thing we are always interested in is how much of the sequencing newborn screening labs would be part of, and how much you would know about the genetic changes and things like that. It sounds like you guys are really involved in it, which is really great. It might vary state by state, but that's really interesting. I know there's some hot chats going on in the chat room. So it looks like, so is there anything else you guys want to talk about related to XALD or other state reports? Just a reminder, so we had a March update from New Steps team, and I know there are a few folks from New Steps on the line. So New Steps, do you guys have anything new you want to talk about today? Or reminders? they're still recovering from the symposium in Chicago, which was a great time. So if they have any updates, we'll make sure that we add them to the notes. I think last time they talked about if any states need technical assistance to contact them for the new disorders. For NBSTRN, I just wanted to remind everybody that we're part of a New York State and Parent Project for Muscular Dystrophy-led effort to pilot Duchenne newborn screening. So this is sort of on the research side, where we kind of have our focus at NBSTRN. So we're trying to think through all of the unique things that go along with newborn screening for an excellent condition, for a condition that when the babies are born, they may be asymptomatic clinically, where there's some molecularly targeted therapies for maybe 10 to 30% of the cases that are newborn screen identified, as well as a screening test that may identify muscular dystrophies beyond Duchenne. So thinking about how do you reflex to a next generation sequencing and even a gene panel. So there's a lot of different issues we're thinking through. You can contact Dr. Kajana and her team who are leading the laboratory screening side and working with 2 hospitals in New York. If you have any questions or as the pilot's going to get underway, I think sometime this summer, we can definitely give you updates, but this isn't anything that's ready for prime time, just something we were working on the research side at NBSTRN. As you guys know, NBSTRN is starting their another cycle of 5 years. So we're doing some upload or upgrades to our website as well as to our tools. If you go to our website, you might hit no longer there. So if you're looking for anything, just feel free to reach out to us as we build a new website and build some of these tools. We'll be working with 2 new subcontractors, Insomniac Design, who's a firm in the DC area, and Databricks, who's a genomics pipeline firm out of the San Francisco area. So we'll be updating some of those tools and hopefully enlisting some of you guys to try them out and see if they make your lives any easier. Just a reminder that we have this call on the first Thursday of each month. Please, this is really a forum for all of you to share your information and to discuss things. You know, we have the SMA pilot. That's an active NICHD supported pilot. We think that there'll be another announcement of a pilot this year, as well as a recompetition of the IDIQ task order in 2020. So that's sort of where our focus is. But if you have any ideas, questions, or things that you'd like us to bring experts in to talk about in an upcoming call, in addition to what we talked about with XALD, the family testing, the clinical impact, the overview of ClinVar and how that differs from the disease-specific mutation database. We'll include those on upcoming calls. So as you guys think about things and you want us to include anything in this forum, just feel free to reach out to us and we'd be happy to do it. So is there anything else that you guys would like to say before we close the meeting for today? Okay, thanks everybody for your time and for all your great thoughts. And I will finalize the notes and send them out. Just a reminder, as we do update our website, these might not be posted right away. So if you need the slides or the recording for anything or want to re-listen to things, just reach out to us and let us know and we'll send it over to you. Have a great day, everybody. Thank you.